afternoon, everybody, and welcome to today's session, which is our Primary Care Network session. I would like to introduce Dr. Chris Tasker, who is going to start us off this afternoon. Enjoy the session, everybody.
Thank you. Obviously, the specification we're looking at is supporting early cancer diagnosis. And this was due to start the 1st of April of last year. And it was basically working with the quality improvement part of QOF, which is early cancer diagnosis as well. And the plan is that PCNs do reasonable steps to improve the early cancer diagnosis for their populations, working with other people. And this is all based upon the NHS long-term plan and the ambitions to increase people diagnosed with cancer at stage 1 and 2 because the outcomes are better. Can I have the next slide, please? We're going to go through the specifications. Next slide as well, thank you. There are 3 main parts to the specification. One is improve referral practice for suspected cancers. The second part is contributing to the improving of local uptake of national screening. And the third is supporting delivery of the above through the community of practice. Next slide, please. Thank you. But it does work hand in hand with the QI QOF of early cancer diagnosis, and therefore it's worth having a look at this as well before we start. This was revised in September of this year, basically because of COVID, and there's now 4 asks of this specification. The first specification is to restore cervical screening to pre-COVID levels. Obviously, during COVID, this has fallen quite dramatically because people haven't been coming into surgery. The second ask is to build public confidence that general practice is a safe environment. The third ask is about referrals, 2-week referrals, that these go back up to the pre-COVID levels and they're of a high quality and that primary care is aware of the referral pathways. And the last part of the QI is to have safety netting in place. These can be done hand in hand, but most PCNs, when they're looking at their PCN work, will try and overlap it with the work so we're not doing things, 2 different lots of work. Can I have the next slide, please? Thanks. Even though there's 3 bits, I'm going to start with the third bit, which is the community of practice. As a PCN, we need to work together with our practices. So the first thing we need to do is actually agree to meet together and to review the situation of where we stand currently, our cancer awareness, our cancer situations, understanding what's happening in our own areas. Different practices have different needs and wants. If you're a practice in a city with lots of students, it's going to be different to one in a city with lots of elderly. If you're going to be in an area of affluence or deprivation, again, your pitches are different. So the first thing is you sit down and have a conversation. Can I have the next slide, please? Thank you. So the sort of suggestion is that you have 3 meetings. This was originally over a whole year, but it's now over a 6-month period because we've been started in October of this year. You have your first meet, then you have a review meet and a second meeting. When you meet, there should be opportunity to share what's going on, share your improvement plan, share your activities. And you should arrange a cancer plan, and the cancer plan should be smart, specific, measurable, achievable, realistic, and time-bound. And at these peer review meetings, basically, we should share learning and update each other's situations. One of the problems with meeting online is we can't see questions. So if you do at any stage get any questions, please do send them in and we'll try and answer them as we go along. Next slide, please. Thanks. Thanks, Sue. The first question I want to ask on Slido was how confident are you about your PCN and your QI QOF planning activity? If you could fill that in and let us know. We'll give you a couple of seconds just to have a think about that. Then one of my colleagues, Joe, who spoke before, will look at what you say and then feed back to us. Great, can I have the next slide? If you need the hashtag again, that's in the Q&A, so it's there if you can't remember it. I'm also working today with one of my colleagues, Fiona McQuiston, who's a CRUK primary care facilitator. And Fiona, do you want to have a speak about this bit?
Yes, thanks very much, Chris. Just what we thought we'd do for the remainder of the session is just to run through some slides and ideas around hints and tips as to how to respond to and meet some of the asks within the specification around early diagnosis. So really these are hints and tips that we've come across, examples of practice and some things that we're hearing already from the work that primary care networks are doing. But when you look at the spec overall, one of the main starting points that it advocates is actually just being aware as to how cancer is impacting on your patient population. So it's about being aware of and looking at some key cancer data trends or indicators to help with this, as Chris has said, in the communities of practice, this initial review of where you are and to set things in motion regarding your planning processes. So you may have heard of it before, but a really good starting point for this is the use of the Public Health England fingertips cancer services data sets. We've got the link for those here, and obviously because screening is a core part as well of the specification, we just wanted to highlight the NHS digital cervical screening dashboards as well is a really useful way to be able to interrogate and review what's going on in terms of your cervical screening. Could I have the next slide, please? Thank you. So looking at the Public Health fingertips data set, this is just a screenshot of what you would see if you follow the link that we've put in there. Just what we wanted to highlight really is really for the first time we've seen the cluster and aggregation of practices at a PCN level, as you can see by the highlighter in red. And interestingly, when you look at this screenshot, the black tab at the top left-hand corner saying summary of indicators is rather usefully for the first time pulled out some of the core cancer trend indicators that were felt to be of most relevance and importance when you're looking at both the PCN specification and also looking at the quality improvement work for the QOF. So it covers things such as the number of new cancer cases within and across a practice and a PCN. It covers all the national screening programmes, given the specification extremely useful. It looks at diagnostic investigations. It covers some of your referral trends, so the number of 2-week wait referrals, conversion and detection rates. Interestingly as well, it offers the opportunity for you to collectively review and benchmark performance. So it's aggregated in such a way that you can see the PCN averages for some of the indicators and also the England benchmark for those indicators as well. So it's an excellent starting point actually. And when we're thinking about quality improvement work, it's really just important to know what your baselines are, what your starting points are as you travel from A, B through to C. So being able to monitor and articulate and demonstrate where improvements are. So looking at the data is a useful exercise, not just at the beginning of the planning process for your work, but throughout. And some of this will kind of reflect between using these types of data portals and things aligned with how you use searches on your clinical systems as well. What we would advocate is at this point in time, the CRUK facilitators have provided a lot of support for PCNs and individual practices around providing data packs to be able to exhibit and present in an accessible and useful way with some commentary some of the key cancer trends for your given population. The other thing to highlight as well, just interestingly about Public Health England fingertips, the data is slightly retrospective, so it's roughly about a year lagging behind for most of the indicators. But having said that, considering some other cancer data sources and data sets, that isn't necessarily too bad. However, thinking about the NHS digital cervical screening dashboard that I just mentioned previously, that gives you a lot more of a real-time indicator as to your cervical screening coverage, for example. It only runs about 6 months behind real-time monitoring of coverage. Moving on to the next slide. With the cervical screening NHS digital dashboard, this just gives you a screenshot of what it looks like. And I think of interest as well for practices is if you look, and for PCNs, if you look on the right hand side, it actually shows you the coverage rates into the two core age ranges for invitation. So you'll be able to see actually there's differences in coverage depending on a woman's age and whether it's more of a challenge inviting younger women as opposed to older women in for the screening programme. As I said, it also provides benchmarks at a CCG level, so you can both find your individual practices there and see some benchmarking against CCG averages. Next slide, please. So just looking at the data packs and planning support, as I've said, data packs have been produced and are available to PCNs as produced by your Cancer Research UK facilitators. At this point in time, every PCN will be able to access some of the support from a CR UK facilitator. Just follow the link that is placed on this slide, just to highlight that these slides will be on the Northern Cancer Alliance's website, so you'll be able to activate some of the links and useful hints and tips to come. The other thing that, as well as developing the data packs, some of the facilitators in the team have come along and supported the initial conversations at a PCN level when you've had the first community of practice meeting, which has been quite valuable for some, and have come in subsequently to help with some of the planning of mini projects and helping to formulate plans as a consequence of the review of the data and indicators. Next slide, please. I'm going to hand back over to Chris.
Thanks, Fiona. A couple of things. First, as Fiona is a CRUK facilitator, it's important that I say that they're very good as well. And I was certainly found them very, very useful in our own PCN. And I've worked with Fiona a lot in Newcastle, and my colleagues have worked with the other facilitators around the region. So I really would put them forward as being a very, very helpful resource. Joe, could you let us know the results of that first Slido, please? Thank you. Yes.
So how confident are you about the PCN DARES and QOF QI planning and activity? So A was very confident, and we had 0% of responders to that one. B was somewhat confident, and we had 33% of the responders acknowledging that one. C, not confident, so this was the overall majority, was 50%, and not applicable there was a 17% score.
Thank you, that's very helpful. Let's hope at the end of the meeting that those figures improve. Can I have the next slide, please? Thank you. Now I'm going to move on to the next bit of the DES, and this is improving referral of practice, and this actually is divided into multiple pieces. The first piece is to review the quality of the PCN referrals for suspected cancer in line with NICE guidance, but it also has including the use of CDS tools, which is cancer diagnosis support tools, and the reviewing of practice data, and also looking at the RDCs, which is rapid diagnostic centres. We'll come to those two more in a minute. The second part is about safe netting again, and the third part is about patient information and patient leaflets, signposted about why they're being referred. So we're going to do these in more detail. Can I have the next slide, please? Thank you. The first thing is reviewing or auditing your data, and certainly this can be done in different ways. And there's two main areas people will look at their referrals. One way is to do a retrospective audit of all referrals, so patients with or without diagnosis of cancer, but it's looking at the quality of your referral. And this can be done by a site, say lung cancer or lower GI cancer, over a time period, or it could be all cancers over a certain time. The other way of looking at cancers and auditing is looking at cancer diagnosis. This gets a different group of patients, because in this group you can look at people who have a diagnosis of cancer. Some will have been diagnosed by 2-week rule, some will be incidental cancers, some will be screening, but some will also be diagnosed through emergency admissions and things. And again, you can do this over a time period, or you can do it over a certain cancer, say lung cancer or whatever. And some people may just prioritize looking at cancers diagnosis through emergency admission, because this is often the more difficult group. Thank you. Go to the next slide, please. When you're doing your audits or your reviews, you should be looking for learning points. What can we learn from looking at these patients? This may be looking for delays. This could be a patient delay. It could be a primary or secondary care delay. You should also be looking whether safe netting was used or could have been used. Looking at missed opportunities. Did a patient present and could have been referred earlier? What can we learn from this? When you do your audits, it's very important you look at all the patients that have been referred. Unfortunately, some patients will leave, some patients will even die. And the patients who die often have the worst cancers, the stage 3 and 4 cancers. So it's very important that you include these patients in your audit or your review of data and situations. Can I have a next slide, please? Thank you. In my own practice, partly because I'm a cancer lead, I've been doing this for quite a few years, and these are some of the learnings that I can remember that we've picked out ourselves. One of the first ones we learned when we first started looking at our referrals was lung cancer, and we have a very low threshold for doing a chest x-ray. I work in an inner city practice with high smoking rates, with lots of COPD, and lots of people were coming in and not having a diagnosis of cancer done early. One of the areas was recurrent chest infections. This is slightly complicated these days because patients don't just come to primary care. They may go to casualty, they may go to a walk-in centre or an urgent treatment centre. So just being aware, if they've had multiple infections, consider a chest x-ray. The other one, which I've seen in my own practice, but also in other practices when I visited practices to review their data, is that people with shoulder pain. Sometimes people would have an injection to their shoulder, the pain wouldn't get better, and eventually you do a chest x-ray and find they've got a cancer, which is causing their shoulder pain. Another area is microscopic hematuria. This is no longer a direct 2-week referral, but I've seen this in many practices, had great difficulty in knowing how to deal with patients in this. And some patients were missed and some patients weren't followed up appropriately. In the last few years, another one which we saw in my practice was people who have abnormal lumps and bumps in their head or their neck. Some of the clinicians were organising an urgent ultrasound, whereas really they should have gone straight to ENT, because they would have had an ultrasound when they were seen, and also they would have had a fine needle aspiration or a biopsy at the first appointment. So us doing investigations in this case causes a delay. And the other thing, when you look at patients who've been diagnosed with cancer, they could have used, if you have it, the serious but non-specific symptoms pathway. And certainly in my practice, there was a few patients that could have used that pathway that didn't do that. Next slide, please. Thank you. So once you've done your audit, looking at things, the other thing that is hoped is that GPs are aware of all the different pathways that are present. One of the newer pathways that's coming in soon is going to be called the Rapid Diagnostic Centre or Pathway. And this is a cancer decision support tool. This helps GPs. Not everywhere, I don't think anywhere's got one yet, but a lot of the trusts in the area are looking at the RDCs and just developing these. And this is for what I'll come to in more details, but this is something which may be very useful. And your PCN might say, let's have an educational meeting. That could be CRUK, it might be your GP lead from your CCG to come and just talk to you, or it might be a secondary care physician that will talk to you about what's happening in your area, how you can use that. And that would meet the criteria for understanding your pathways. In some parts of the Northeast, certainly Newcastle, Gateshead, and Sunderland and North Tees, there's what we call a vague symptoms or a serious but non-specific symptoms of cancer pathway. And again, not all GPs know about this. Not all GPs can use this. So it's important that everyone is aware of it and uses it if it's available. And the last thing is, if you don't have an RDC or a vague symptoms pathway, there are other tools out there. And one of these tools is Q Cancer. Can I have the next slide, please? Why do we need diagnostic centres? This is some data from 2016-17. This is patients referred on a 2-week pathway and those that had different treatments. And I'll put it in easy to see on the next slide. The next slide, please. And looking at people who were referred under the lower GI pathway, 1,061 people in that year had a lower GI, had a cancer, sorry, but only 891 of them had a lower GI cancer. And as you can see, others had other cancers who were missed. So if you just look for one cancer, some of these people wouldn't have actually had this diagnosis made. And with changes happening at the moment regarding fit and things, there's a risk for these other cancers could be missed if there's a change. So with a rapid diagnostic centre, can I have a next slide, please? Things are going to be done differently. They're basically at the centre. We're hoping that it's going to transform diagnostic services. This is a government slide. Achieve more efficient pathways, support the faster diagnosis standard. If a patient has lower GI cancer on the lower GI cancer pathway, they'll probably get the diagnosis, well, they would have done before COVID, within 28 days. At the moment, that's the challenge. But if they had a cancer, which is lung cancer or renal cancer, they have to go in and out to different tumor groups, and that delays things. And these people are taking a long time to get their diagnosis made. So Rapid Diagnostic Centre will help achieve a faster and an earlier diagnosis of cancer. It'll also improve the patient experience of their cancer diagnosis, because they won't be hanging around or waiting for things to happen. And the hope is it will reduce unwanted variation, and it should also be supported by things like radiology and pathology. Can I have the next slide, please? Thank you. This is another way of looking at the same data, that the plan is to have early identification and a timely referral, but they'll have a broad assessment. So if I refer a patient with multiple symptoms, which are partly lower GI, but others, they won't just get a colonoscopy. They'll get other investigations. If they have weight loss, there may be a CT, chest, abdo, pelvis. And secondary care will be involved at this stage doing the broad assessment, and they will do the coordinating of the testing. And they'll also make a timely diagnosis. And the last bit is part 6, is to refer onwards. This shouldn't just be for cancer. Any referral that's needed should be happening. And there's an overarching plan as well to have excellent patient coordination support, so that patients will be supported through the whole pathway, so that rather than getting lost between different departments, somebody actually will help and ensure that the tests are done in a quick and timely manner. And that will obviously help patients and take the stress out of their situation. Next slide, please. Thank you. This is a copy of the Newcastle serious but non-specific cancer symptoms of cancer pathway. It's based on the Oxford model, and it's for people who do not meet the current 2-week referral criteria, who are over age 40 and have one of these other symptoms, at least one of these symptoms. That could be unexplained weight loss of 5%, severe unexplained new fatigue, or persistent nausea and appetite loss, a new atypical pain, or GP gut feeling. And with this group of patients, the GP will see them, assess them, do some bloods, and if they still, and a fit test and a chest x-ray, if they still don't meet the 2-week criteria, they go on to do a CT scan of chest, abdo, pelvis. This is currently in Newcastle having a pickup of about 10% of people referred will have a cancer. And that's the figures, I think, from my understanding, around the whole region. Next slide, please. Some parts of the region still don't have a vague symptoms pathway, and they don't have an RDC. But acute cancer is another way of assessing a patient if you're not sure what's going on, but you have a worry. This is available, I believe, on EMIS. I'm not an EMIS user myself, but it's also available on the internet. And you can basically Google, and then you can put in the different symptoms, the patient's age, the postcode, whether they smoke, and it'll bring up a risk of their cancer. And obviously, if only one cancer that's above 3%, that justifies a referral. Or certainly further investigations. And if they don't meet the pro forma, if there's a concern, I think you could write a letter to the hospital and say it's a 2-week rule and say, I'm concerned because of the acute cancer risk of this, please could you advise the best way forward? It's a very useful tool. Hopefully, as the more tools we get to support us, this will be less needed, but it's still there for some people. Next slide, please. Thank you. I'm going to pass it back to Fiona.
Just in relation to this then, as Chris has said, when we're talking about supporting faster diagnosis of patients to facilitate earlier diagnosis, and also looking at things as the serious non-specific symptoms pathways, we just wanted to highlight actually as a region, there are a lot of things that are progressing and developed, have been developed or in development that would be useful just to be aware of at a PCN level. In terms, as Chris has just said, about checking in with practices that they're aware of it, how they are engaging with new pathways or changes to pathways, the opportunity to facilitate joint learning or some educational updates either virtually or just via sending out appropriate update bulletins, for example. So we just wanted to highlight, really, as a region, there's a lot going on. So being aware of these, incorporating them into your reviews and discussions is a good thing. So we've got the vague symptoms pathways, as I say, or the serious non-specific symptom pathways. As Chris highlights, they're in Newcastle, recently launched in County Durham, South Tees, North Tees, Gateshead, and the area, and Sunderland. So it is just about seeing, you know, our practices, engaging with them, how they're finding using those pathways. Essentially as well, fit symptomatic to aid clinical decisions as part of 2-week referrals for lower GI have been significant development. recently. We've also seen with the fit symptomatic the changeover to a postal service in most areas in recent months. So again, it's just an opportunity to explore how fit symptomatic testing is being used as part of the 2-week wait referral process, and indeed triage and clinical decisions. Interestingly as well, within our patch we have 2 lung health check initiatives. So in South Tyneside, it's been going for a while now. We have what we call the local lung health check servicing scheme, which is looking at targeted offer of spiral CT for those patients who are at higher risk of developing lung cancers within a certain age range and related to their smoking pack habit. Interesting, within the Newcastle and Gateshead CCG area, the area has been chosen because of its high smoking prevalence and incidence of lung cancers as one of the first wave national lung health check pilots. It's yet to be operationalised. Obviously, we've had some delays due to COVID, but that is coming. So it's to be able to watch out and engage in that. Again, an ideal opportunity for updates and education, which will fulfil many elements of the PCN specification. I think we've had sessions on this afternoon about teledermatology. I'm aware that in some PCNs they're looking to incorporate their work and piloting and beginning to engage with teledermatology in relation to skin cancer detection as part of their PCN plan. So we've got teledermatology rolled out obviously in County Durham, Northumberland and Newcastle. Also to be aware of, obviously, as we know, cancer pathways are extremely complicated at times, and we've seen in secondary care over the last couple of years the introduction of care navigators. So just being aware of those as new staff members that may well come in contact to the practice and are a valuable support in seeing patients through the pathway and potentially reducing delays. Obviously, with the PCN specification, we've seen the introduction of some new posts and roles via the R schemes, such as care coordinators, to work across practices and within primary care networks. Some PCNs have been looking at these roles badged against cancer and looking at those being specifically dedicated to providing extra support around the cancer agenda, including the early cancer diagnosis agenda. So looking at elements around their role in promoting screening, symptom awareness, helping to support patients through the early stages of the pathway, as obviously they're undergoing investigatory tests and move from primary into secondary care. So it's just some food for thought there, and actually there are some training offers that are available if you want to look at some of those care coordinator roles in that way with a cancer badge. I'm just going to hand back over to Chris. Next slide, please.
Certainly with the PCNs, there's no one way of doing a lot of these things. You can choose which pathways you think are helpful for your PCN. You can choose which audits. We're just giving you examples of what we've done. That doesn't mean they're the right things. As long as you do something which is helpful for your patients and improves your patients' care, that's completely fine. Safety netting, this is one which we all have to do. Well, I'm pleased to say it's part of our everyday life. Can I have the next slide, please? This is from an MDU article, and it doesn't just apply to cancer. And I'm just going to very straightforward and just read it, I'm sorry to say. In general practice, doctors see a huge number of patients with symptoms which may or may not be a presentation of a serious underlying condition. Patients present at different stages in their illness and will have different thresholds for seeking medical advice. Safe netting is important where a patient may have a risk factor for a specific disease or where a specific complication are recognised as part of the illness or the treatment. Safe netting involves ensuring that systems are in place to provide safe monitoring and follow-up, as well as specific advice to the individual patients by the clinician. We all recognise this. This is not just for cancer. This is for all of our day job of being a doctor. We do this every day. But just for the cancer side of things, there are some specific asks. Can I have the next slide, please? Most of us don't read the suspected cancer recognition referral guidelines all the time, but in that there is a section on safety netting. We're kind of more familiar with the referral criteria, but it does also include safety netting. Can I have the next slide, please? Thank you. I'm going to pass back to Fiona again to take us on.
So this, just going back to it, this infographic, what it actually represents is potentially how a patient might move through a 2-week wait referral process, or indeed investigatory tests as part of an investigation to exclude cancer, or indeed to diagnose cancers. What it shows is just at key levels, at points in this pathway where safety netting should be considered and what types of safety netting. It works on a model introduced by the Oxford Safety Netting model, which essentially looks at 3 components: communication and advice to patients, the actions to be taken by the GP, and the actions to be taken on a practice level, which is about systems and processes. And what this does is actually, it's a really good starting point for maybe one of those review conversations to reflect on what practice is going on across a PCN or within an individual practice. It's an ideal tool also if you are a training practice as well. It's quite useful in that respect. Could I have the next slide, please? Thank you. So as I said, within this workbook and aligned to the Oxford Safety Netting model, it revolves around 3 components. I'm not going to go through every line on these slides, but essentially what I'm suggesting here is using this workbook as potentially and seeing this as a checklist or an aid memoir to have that initial conversation with colleagues, both clinical and non-clinical, at a PCN and a practice level about what does safety netting mean for you as individuals, what is occurring, what is happening, what is in place for safety netting across the practice and as a collective. It asks as a checklist and maybe a prompt for review because it comes up with some key things which were identified as part of the development of this model as good practice, or conversely, where unfortunately patients had slipped through the net because some of these things weren't in place in a robust and consistent manner. So if we're looking at communication to patients, it's about ensuring that patients have understood the rationale for any referrals, the importance of attending any appointments in secondary care or investigatory tests. It highlights the key points that patients should be aware of in terms of time course of symptoms, how to access investigatory results. It also looks at key things around the information that can be provided to patients, and also with a call for us to consider looking at information being given that's appropriate in different formats, easy read formats, or indeed different languages. So this is about ensuring that the patient understands from their point of view what the clinician is looking for, what are alarms, when to represent, and what to expect next in their pathway. So basically, it's about, do we all do this? Do we do this in the same way, and do we do it in a consistent manner? Could I have the next slide, please? The next item is really around actions at a GP level. So this is actually looking at what the GP does essentially during the time of consultation, following consultation. It's really looking at here around care, what's in the care plan, what's documented in the care notes around safety netting. If you weren't continuing to provide the care for this patient, what needs to be included in this patient's care plan or documented in the notes that would make it easier for a colleague to pick up. It looks at key things around suggesting about how are you aware that if results have come back in, do we have follow-up results? Do practices know and clinicians know when a patient hasn't maybe attended for an investigatory test and how they can be followed up? It looks at recording symptoms, potentially coding symptoms, being available and able to recognise and search for core repeat symptoms if, say, this patient was seen by several different clinicians. It looks at ways also of being aware of how often the patient has maybe represented. So it's looking at those documented care plan notes that can be picked up, but it's about just having that conversation about how do individual clinicians and the practice approach some of these issues. Next slide, please. The actions for the practice, that really again focuses on both systems, frameworks and protocols within the practice that can be easily communicated to patients, such as how do you access your results, how are abnormal test results communicated, for example. It's about how you provide obviously the operational building blocks to track patients through their patient journey, investigatory tests, whether you do know whether a patient, as I said before, is attended vital appointments or is engaged in the investigatory test that's needed. So basically having a look at these maybe core components as some sort of a checklist or an aid memoir to facilitate a review, a discussion at a PCN and a practice level to see if, one, there are definitely consistent, robust systems in place, tick, that's great, or where maybe it potentially falls down or there are gaps, or you might do things differently where potentially that could lead to maybe a patient falling through the cracks rather than being adequately monitored and supported through the pathway. So just got to bear in mind, this isn't about questioning necessarily whether you're doing the safety netting. In some elements, it's about being able to understand whether there's a robust, consistent procedure and protocol that is shared across clinicians, that is recognisable. I'm going to hand back over to Chris.
Thank you. Next slide, please. Thank you. In the past, I used to visit practices for their cancer plans, and one of the things used to always come up with these kind of events where things went wrong. And in my own practice, a lot of these things we've all seen go wrong. Therefore, safe netting is important. And at my own PCM, we sat down and tried to agree what we thought could be a minimum standard. These are some suggestions. The first one is that patients who are referred on a 2-week rule are seen at secondary care, and that's actually one of the ones in the NICE guidance. It's there, particularly in black and white. So that one probably I think is a must do, and that can be done in different ways. The second one is that a patient who wants to defer their referral can be deferred until the appropriate time, because they're supposed to be available for 2 weeks before. In the past, this was in my practice, was people working offshore who weren't going to be around for 3 weeks because they were doing a two-week shift back offshore. Now with COVID, the plan was the concern was that some people wouldn't want to go to hospital at the moment, but still want to be referred at the right time. I can't think of any patient that had suspected cancer in my practice, but I did have a patient who had query angina who refused to go and have investigations at that time. The third example is if you're doing a test to exclude cancer, do you safety net these? So if you've got a raised CA125 and need to do an ultrasound of their ovaries to prove for ovarian cancer, how can you be sure they've gone for that test? If you've got somebody with weight loss and you're sending them for a CT scan for pancreatic cancer, have you got systems in place to check this is happening? That probably had the most conversation at my PCN of whether we should do that or whether we can do that. My understanding is that if we're suspecting cancer, we have a responsibility to ensure that we exclude it and support the patient through that. The fourth suggestion is, what do you do to support your locums? If a locum comes just to do one session and not come back again, they're not going to know how your practice works. How can you ensure that if they've seen somebody that needs a referral for a 2-week rule or whatever, investigations, that somebody takes ownership of that patient's situation and follows them up? And the other one, unfortunately, I've had in my own practice in the last few years, is people going off suddenly ill and been off for 2-3 months at a time. So many of the GPs have their own safety netting. They'll task themselves on system 1, check that result comes back. But if they go off sick for whatever reason, they can't do that. How can we check each other's work? How can we have either a buddy system or an admin system that checks these things out? The last two, robust systems for results. I haven't met a practice yet where they haven't had a problem at some stage with the result, where a patient has either hasn't rang up for the result, I thought it was okay because you didn't contact me. Do you have systems in place to ensure that if something's abnormal, that it's followed up? And sometimes it could be a normal result needs to be followed up because you need to find the reason why something's happening. And the last group is those patients who have ongoing monitoring. Do you have systems in place? Many patients now discharged from secondary care with their PSA monitoring to be checked every 6 months. And certainly, I'm aware of a patient in one of the CCGs who was supposed to go home for monitoring of PSA, and then 3 years later was found to have prostate cancer and hadn't had any monitoring at all in the 3 years because that had slipped through the net, unfortunately. Can I have the next slide, please? Thank you. There are different ways of doing safety netting, and the simplest way in some practices is having a spreadsheet. And many practices will have somebody in admin who will actually upload the 2-week referrals, make a note that a patient's been referred, then also make a note that they've been seen. There has been a nationally agreed SNOMED code or READ code for cancer safety netting. It's not quite sure how we use this, but it's been developed so it can be used. Many practices use, as I said, like in System 1, we use tasks. I think EMIS, you have a task set up as well, but it works slightly differently to the way in System 1. But we'll do this, and that's very good. So I can see the other tasks my colleagues make for themselves. So if they go off sick, I can look at their task and see what's outstanding and chase it up. There are a few other templates out there. One is in EMIS, and there's a YouTube shows you how to use this. It's built into the system, but it has to be activated. It's not activated, then you can't use it. In System 1, there's some work done on building a demo of what you could do with System 1. It's not so robust, but further work is happening, which Fiona will tell you about shortly. We've also got the Northern Cancer Alliance has worked on another System 1 document, which is another way of putting reminders in to chase things up. So there are lots of systems out there to help. Every practice, every PCN will have different ideas of what they think works for them. But as a PCN, you need to sit down, agree what you think is the minimum standards, and then work out how you can support each other to do that. This is one of those times where you can, again, share good practice, share what works well and what hasn't worked so well. I'm going to pass back to Fiona for the next bit. Next slide, please.
Yeah, so one of the things that we just wanted to highlight now is that within some of the clinical systems, there are either in development or there are already in existence some safety netting templates. So one of them that is already fully developed and just needs to be activated sits within the EMIS clinical system. And as you say, it comprises of 4 pages and enables to support for safety netting around suspected cancer referrals, direct access to diagnostic tests, so you can add a diary entry for follow-up of results, active monitoring of patients with symptoms, so what we refer to as patients with low risk but not no risk who require monitoring, with some free text in there for you to put in your plans, for example, for follow-up tests, and to set a recall date for that patient or follow-up for the test results. And also for monitoring patients who have cancer or pre-cancerous conditions such as PSA monitoring, or maybe wanting bloods on a 3-monthly cycle. So the EMIS template actually covers several different functions. I know people either love or hate the use of templates, but it might be worth clicking on the link that we've got on the bottom of this slide, just to have a look at whether this inbuilt EMIS safety netting template is something that could work across your PCN, or the PCN could be an advocate for using and sending out the information. If you need any assistance on that, please get in contact with your Cancer Research UK facilitators. They'll help in relation to that. It doesn't preclude you from obviously maybe developing your own templates, but having a look at this may be a really valuable starting point. Next slide, please.
And Fiona, is there any work going on for System 1 to templates and things?
Yeah, there is. So basically, just to highlight, Chris mentioned the System 1 clinical template. So you can actually access this on the CR UK contract hub, but just to tell you a little bit about it, one of the CR UK GPs in the West Midlands developed a safety netting template for his practice for System 1. What we're currently doing at the moment is working with Next IT and 2 lead GPs around templates in our region to get that fully adapted, functional and up and running for System 1 practices, so that it will be able to be accessed on the DCS platform that I think a lot of System 1 practices are used to using. So obviously we're working with the likes of Gareth Forbes in County Durham in relation to that. So we would, if you're interested in that, your CRUK facilitators working with CCGs and your GP clinical leads and CCGs will be able to update you on that, but we're trying to get that expedited as quickly as possible. I'm just going to hand back over to Chris now.
Thanks, Fiona. That's brilliant. The last bit of improving referral quality is patient information leaflets, which I think is quite interesting because partly to me this is a safe netting tool. There is the Safeguarding Incident Risk Management System, which has been put in place, or SIRMS, and on there's been a cancer button put in by the Northern Cancer Alliance, and on there the commonest concern in primary care is the failure to send a 2-week referral. And there are two things which happen in this situation. If the patient's been given a leaflet, within a week they ring up and say, I've not had an appointment, please let me know what's happening. If they've not given a leaflet, I know of patients who've waited 3-4 months before they've rung back saying, yeah, it's been very busy because of COVID. I'm sure I didn't get an appointment because of COVID. And what's happened is, for whatever reason, the letter hasn't got to the secretary or hasn't got to the hospital. So for these patient information leaflets are really important to safety net those referrals to ensure that people get, and they help include the patient in what's going on. The leaflets will also give you more information about what the patient may expect. They tell them it's for a cancer. If it's for a cancer, yes, it's upsetting to be told that, but they're more likely to attend if they know what the reason for the referral is. So that can be really helpful. Can I go to the next slide, please? On all the 2-week referral forms, there is a hyperlink to the different leaflets. And if you press on the hyperlink, it takes you through to this page on the website, which you see on the right-hand side. And each hospital, each trust has a different leaflet, because usually there's a telephone number on that leaflet to phone the hospital to say, I haven't got my appointment. The second thing to say on this, there's also an easy read version. Some of our patients don't have great reading skills, have learning disabilities, and that can be really helpful for that group too. And my understanding is, I'm not an expert on this, that Recite Me has been added to the Northern Cancer Alliance website. I'm not an expert, but it's there, and one day I'm sure I will use it. But that, my understanding, puts things in other language, leaflets in other languages. Is that right, Joe? I'm making Joe speak.
Yes, what Recite Me does is it will textually translate into a vast number of languages, and then about 60% of those will audio, and then it has a whole host of reading tools, so for visually impaired people, so rulers to be able to follow lines, space the text, change the colour. So it's a whole accessibility toolkit across the whole Alliance website.
Really helpful. So thank you much. Thanks, Joe. It's really helpful. Thank you. Can I have the next slide, please? Thank you. Back to Fiona for an example.
Yes, this was another thing, a potential resource or a starting point or an aid or somewhere to get a little bit of inspiration from. Again, on the CRUK contract hub for the PCN spec, they've introduced a section on there that has a range of case studies. So the case studies actually banded against the core components of the PCN specification, and there's several different examples of work programs that PCNs have championed, taken forward with their constituent practices, and many of these are just are real examples that we've come across, and it's our aspiration to keep on adding to those. So hopefully these can be a potential, as I say, site for inspiration. The one that we've got here is just in relation to safety netting, and as you can see from this, basically the PCN put together a specific SMART objective around improving safety netting around 2-way referral pathways, and what initiated that for them was concerns around the impact of COVID-19. So basically the background to it was what they were aware during the height of the pandemic, there were some issues in relation to patient confidence around presenting, changed behaviour and attitudes about presenting with symptoms, changes to patient pathways, some instances cases being deferred or downgraded. So as a result of that, actually what this PCN decided to do is that they would do an audit of all the 2-way referrals that took place or were initiated during the height of the pandemic. and to the present day. So in all, they kind of audited over a 4 to 4 month period. Interestingly, in doing this, it also gave them the opportunity to not just explore safety netting, but also explore patient cases. So they used it for both elements of the spec in some respects, proof and work around safety netting and reviewing quality of referrals. Basically, the PCN encouraged also at the same time the practices to actually set up a 2-week referral tracker log. As Chris has suggested previously, this could be as simple as an Excel spreadsheet set up and populated and managed by a member of the non-clinical team. They were an EMIS practice, so they activated and decided to trial and use the EMIS safety netting template, and they sought advice and used some of the CI UK safety netting infographics, hints and tips that have been produced during COVID. And interestingly as well, they made sure and championed people responding and having a look at the Royal College of General Practitioners telephone consultation guidance during this new world to ensure best practice, and just for some hints and tips there. Interestingly as well, what they focused on was ensuring, as I've mentioned before, when you're thinking about your plan for that patient, the care plan, making sure that safety net and advice is recorded and actions are in the notes. And with the introduction of the National SNOMED code for safety netting, they made sure that when a 2-week referral was sent off by often a non-clinical member of staff, that the SNOMED code was initiated and put on the patient record, so that search could be done laterally to make sure and to help to make sure that they know that that referral is where it should be and that patient is where they need to be within their pathway. So interestingly, there was a whole host of activities that the primary care network championed, took forward, discussed and got an agreement with their constituent practices to take forward. What we do know in relation to this area, that actually they also, obviously as part of their audit, could see what kind of demonstrable, recognisable safety netting systems were in place, and their baseline was sitting at about 40%. A few months afterwards into these new systems, they saw a notable increase in recorded safety netting in patient notes. Interestingly as well, the audit actually identified 2 patients who had had their appointments and diagnostic tests postponed during COVID, so they'll be able to pick them up, which again for them strengthened the argument of using the EMIS clinical safety netting tools and also the 2-week referral tracker system. I just think this and some of the other case studies on the website just show very, very succinctly some of the plans that can be put in place and some of the discussions that practices have had collectively and what they've decided to take forward. I'm just going to hand back over to Chris.
Thank you. Next slide, please. We're going to do another Slido. This time it was basically asking you to put any observations, queries or challenges that you have, any questions, and then just basically type them in. Is that right, Joe? Yep. So if you could type any questions or observations or challenges in, it'd be very helpful. If there's something we're not covering you'd like us to cover, let us know, please. And we'll look forward to anything you want to ask us. Thank you very much. Next slide, please. Thank you. We're now going to go back to screening. So unfortunately, Fiona doesn't get much of a rest.
Thanks very much. So in relation to screening, so this is, as we said, the other key component of the PCN ask within the specification. So I'll have the next slide, please. So just to recap again as to what the ask is within the specification. So just interestingly within this one, the ask is for PCNs to contribute to improving the coverage of the 3 national screening programmes. And interestingly, the main emphasis on this is working in collaboration. So this isn't necessarily, it's not asking you to kind of reinvent the wheel. It's being able to connect to and work with local partners, being aware of potential and existing initiatives that are being progressed within your geography or your area. So I'll give an example of this because we've got a few interesting ones within our region. So we've got the regional cervical screening saves lives initiative. So that is, if you haven't heard of it, it's focused on cervical screening. It was something that has been championed by the Northern Cancer Alliance following some really positive pilot work within Middlesbrough and the Newcastle area, and it's a social marketing campaign, looks very different, very targeted around improving cervical screening within our BAME community and areas of high deprivation. The reason why I'm suggesting this one is it's a prime example of how if practices engage in that initiative, it also demonstrates, because it is a multi-agency programme working with local authorities, into communities, with community providers, the acute trusts and the labs. So it's a prime example of, you know, being a champion of that, engaging in that, and I'll come on to it in a little bit more detail, helps you to demonstrate how the PCN is connecting in to their local systems and partners. It's also about encouraging dialogue, sharing good practice skills, knowledge across constituent practices as well. So providing almost like mini communities of practice potentially to be able to look at this issue together across different staff within the practices. And ideally as well, when we're talking about the screening coverage for the PCN spec, there is a very strong emphasis on improving population health, addressing inequalities, and an ask to focus and identify what your low participation groups are locally, and to do some targeted work with them around screening coverage. Next slide, please. So thinking about increasing screenage coverage and uptake in relation to QOF as well. So as we've mentioned, the PCN spec and the QOF are very much integrated. Whilst the first slide demonstrates what the ask was at the beginning of the financial year, we did, as Chris highlighted, saw some changes being introduced in September of this year, and there was a greater emphasis now and a focus on restoring cervical screening uptake to pre-COVID levels, because obviously the programme was stepped down and delayed for a period of time. And also the other bit about this was also just generally improving screening coverage. So it's got more of a focus now on cervical screening rather than all three of the national screening programmes. Interestingly as well, what was introduced in September was a potential double QOF points in relation to improving cervical screening coverage. So consequently, what we've seen is a lot of primary care networks have maybe shifted their focus slightly to look at cervical screening now. It's not to say that you still can't look at others, but this cervical screening has kind of come more to the fore. As I've said, practices should share, what we're suggesting is practice should share what works well across practices, provide that opportunity for some joint sharing and networking, and spend a bit of time considering what are their low participation groups, and also some time looking at and tracking where are we in terms of dealing with our backlog. Are we on top of that? Do we still need to do a little bit of work? And as a consequence of that, maybe looking at how you work across practices in relation to capacity or extra clinics related to extended hours programmes as well. The other thing around this, what we would advocate, as I've just said, tie into some of the regional initiatives such as the Screening Saves Lives. And the other is, I think we've got tremendous amount of enablers within this region as well. A lot of the CCGs took forward work with CRUK and local practices about introducing non-clinical cancer champions within their practices. So These members of the team have had some very specific training around early cancer diagnosis, what's involved in the screening programmes, how to promote screening, how to identify non-responders, how to have some opportunistic motivational conversation with potential non-responders. So I think we've got a lot of enablers around this one. So we've got the screening programme, that regional initiative, we've got non-clinical cancer champions and a lot of our practices. And another good foundation in relation to this is in some areas we have had community cancer awareness workers funded by the Northern Cancer Alliance, and given the specification for QOF now is exploring that expectation of how practices reach out into communities to encourage people to engage. We are seeing some PCNs starting to work with their community awareness workers to look at how you can do work and follow up in practice, and also how you can instill and build confidence in women to return into practice. So looking at the next slide, please. As I said, if we're talking about screening coverage and improving screening coverage, I think the first thing is obviously just to spend that bit of time on a PCN level, understanding who your non-responders are. I often say you can't eat the elephant in one sitting. When we're looking at maybe improving coverage, maybe of benefit here is some really targeted, focused work, targeting people who might be more disadvantaged as a result of COVID, might feel less confident about coming into practice to access the screening. So it's spending a bit of time exploring, using the data, information out there and the indicators to understand who your non-responders are. So we can use NHS Digital, as I've mentioned before, to understand whether it's younger or older women who are posing more of a challenge in terms of coming in and engaging in the programme. Also be aware of obviously the ethnic makeup of your population and the ratio of people with learning disabilities, say for example. So this does require a little bit of an interrogation of maybe of your past QOF performance data, maybe looking at, do you code your cervical screening non-responders, doing a clinical search on there to find out who they are, or alternatively looking on your system to see who has had a third letter and hasn't still come in, and maybe target those women. It's about better use of your prior notification lists. A lot of your nursing staff will be aware of this and using the electronic summary records, because they give you an early indication as to the women who are about to be invited. Are they regular non-responders? So it's about building up a list for you that works, or with some of the practices that I'm working in Newcastle, very clearly in the west end of Newcastle, one of their more challenging and hard to reach communities can sometimes be the BAME community. So it's about looking at different ways of engaging with them. They're looking at using translated third letters, potentially about different ways to use audios or videos on George Trust with text messages, for example. The other thing is as well, it's often a one for debate, is about looking at ghost patients and the challenges of populations, transient populations. So if you're a practice that has a high student population, just having a look at that is a valuable exercise as well. Just going on. As I've talked about, we've just talked about COVID and obviously the importance of restoration now as part of this specification. One of the things I just wanted to highlight, and Chris has done a lot of work on this within his practice as well, is about how do we build confidence back within the patient population to access NHS services in the same way. So there is an ask within the QOF QI specification now, and there's probably room for PCNs to maybe support and drive some campaign work around that and in relation to cervical screening. So is the ways that you can look at getting clear messages back out to your female population that the practices is a safe place to come into to get your cervical screening test. So how can we do that? There's different ways maybe we can do it. One is we traditionally send out third letters, so it's about looking at the content of your third letter reminders, Do you have key messages in there that addresses this appropriately now about, you know, it might look different, the nurses will have PPE equipment, the appointment might take a bit longer, some of the key messages that you need to give women to just reassure them. The other is as well making sure that some of these invitations, as I've said, are in different languages, either written or that you can use. Joe's Trust does have the Recite Me type of package, so you can get information from them as practices, and also you can access some of their videos, for example. We've also as well, another core building block within our area is we've got a fantastic learning disabilities network. So there's a lot of good, easy read materials that have been developed, videos, etc. to be accessed. And a lot of these resources we've signposted on the Northern Cancer Alliance's website as well, so they're all in one place. And the other, we're thinking about restoration and getting to grips with potential backlogs. It's about how extra clinics can be put on, using extended hours clinics, for example, across and within a PCN. So we've seen some good examples of that where we've had catch-up clinics. Next slide, please. So one of the things I just wanted to highlight is this is just in one place. So if we were talking about building that confidence and getting women to engage, it's being aware of targeting your messages to who your low participation groups are. There's a whole raft of information out there. What I would say is our primary care facilitators, the CRUK facilitators, have been doing a lot of work about pulling resources together in one place. We've got some resource packs that can go out to the PCNs, who can in turn promote engagement with their constituent practices around this. I think the other thing is as well, we've got set text for websites, for text messaging as well. We're in a different world now where maybe we would have keyboards in waiting areas. We don't have the same throughput of patients coming through. So it's about looking at your digital footprint now, how you can use websites, how you use your Facebook accounts if you have them, and text messaging. So we've got loads of examples of some innovative ways that PCNs have driven this agenda forward. And we've seen some PCNs are now working to develop videos on their websites to be able just to show or mimic or do a walkthrough as to what appointments would look like or how you access the service. There's ready-made things there. There's the No Fear, Have a Smear practice website. So this is an opportunity for you to place in one place all the things that you have put into place in practice to make it easier for women to attend their cervical screening appointments. Sign up to it, use it, increases your digital footprint. It's an ideal way to, you can make a link to it with text messaging reminders or approaches to women who have not engaged or are about to be invited for screening for the first time. What I would say in relation to this promotion and building confidence element is, don't forget, if you've got cancer champions, what about getting them together with some of your nursing staff across the PCN? I've certainly facilitated a few sessions like that, where people have got together and reviewed what they're currently doing with practice and what they would like to take forward collectively as a driver, as a key message, as a campaign, as systematic ways of working to see what sort of impact it has across all practices. So these are just a few hints and tips and ideas. Next slide, please. Just wanted to make you aware there are a few toolkits available. So we've got the CRUK Cervical Screen and Go Practice Guide. It's got loads of hints and tips, as I said, ready-made letters, text messaging and ideas. And to do with the regional cervical screening Saves Lives initiative, there's a toolkit associated with that. So they are on the Northern Cancer Alliance's website, but also don't forget as well, if you want to train non-clinical staff and help build capacity and skills to look at this initiative, please also get in contact with the CRUK facilitators. They can support that. Also, what I have had discussions with and seen in some PCN areas is they're looking at the new staffing groups that have come in place through ours and maybe training them or giving them some basic knowledge and skills to help facilitate conversations and opportunistic promotion of screening. So, for example, care coordinators have access training. We've had the social prescriber link workers or the health and wellbeing coordinators that are coming into place in PCNs, trained up in core messaging around screening and symptom awareness as well. Thank you. Next slide. As I've mentioned before, this is just another case study example that can be found on the CRUK Contract Hub, and it just shows an outline of how a PCN approached restoration of cervical screening. Again, another live example. And as you can see, a range of activities were adopted. They set themselves a target. They wanted to see their figures increase from 55% to 70% in 6 months. So it's a good example of some smart objective planning there. They knew what the baseline was, and they put an aspirational target as to where they wanted to be. They invested, as I said, in the videos around building confidence. They looked at targeted text messaging, and they identified who their low participation group was. They engaged with community workers and started to distribute through supermarkets and food banks some key information. So they decided in this area that it was younger women in a high deprived area that they particularly wanted to engage with. And as I said, the monitoring of this is ongoing. This is a live example of what they're doing. What we do find is when you're looking at improving cervical screening coverage, if practices adopt multiple approaches, that has a tendency to have a bigger impact on shifting and making improvements maybe than just one initiative in isolation. So I just wanted to highlight that. Next slide, please.
Well done. Thanks, Fiona, for that. One of the things in Newcastle that Fiona and her team have done is help train non-clinical cancer champions in the practice, and they've done a lot of work in trying to increase the patients attending for their smears. So I'd like to thank her for that as well. We've got a question to ask in a second, but before we do that question, if you've got anything about the screening, any sort of questions or challenges or supports needed, please put those on Slido, and then Joe's going to share the question that was being shared already. Thanks, Joe.
Thanks, Chris. So the previous question, the second question, was any observations, queries and challenges you would like to share. So we've had a question in, and it says, such a lot to think about. How do we know where to start and what to prioritise for our practice and PCN?
That's a very fair question, and I think it depends where you start from. One of the things we talked about was when the practices meet together for a PCN, they can't do everything. And one of the phrases Fiona used was, you can eat elephant one mouthful at a time. So you have to prioritise what you think is the most important area. So for my PCN, inner city high smoking, we actually looked at two things. We audited our lung cancer patients' referrals and lower GI. And we prioritised those, one, because lung cancer is bad news in our area with high rates because of high smoking. But two, we wanted to do lower GI because of all the complexities, just to make sure that we all were doing a good job. But in a different area, you may choose to do different things. So you look at your data and agree amongst a group. And I think you have to be, we talked about SMART, and on the initial slide, we missed off the word realistic. And I think being realistic is very important. You can't do everything. And I think this is about just improving step by step the care and provision you give. Obviously, unfortunately, you have to do a bit of referral improvement, a bit of safety netting, a bit of patient leaflets, a bit of screening, but you don't have to do all of those. You have to do all of those, but not everything underneath those. You have to pick one subject or topic in each of those, which is important. And as Fiona just mentioned, that for screening, because cervical screening is also part of the QI, most PCNs are doing that. Do you want to add anything to that, Fiona?
I would just say one of the things is just to go back, sometimes when we've gone in and supported primary care network, starting with the data pack is a good idea. It just enables you to bounce off some ideas, see where the trends are, see where there's maybe some bigger variations across the practice. So that begins to help to identify and bubble to the top what some of the issues could be or the priorities are for you. One of the other things that we've done initially is sometimes we've had a support meeting with the clinical director or the cancer leads across practices within a PCN, and had an initial chat with them and done some support work and just help them to formulate some ideas, so to just help to facilitate you to put a blueprint together. So I just wanted to say that that support is available, and we're quite happy to do that. CR UK facilitators do that on their own or with the CCG kind of cancer lead, or indeed with Chris and Katie. So we're quite happy to come in and have that initial support conversation to help decant out all of the different examples and maybe do a best fit for you. So just want to make that offer.
Thank you very much. We've also got a screening question from Joe. Actually, before I ask the question, I think someone was asking about the slides. These presentations will be put on the website, won't they? Joe can answer that one as well.
I was just quickly typing a response to that one. Thanks, Chris. So the question that we had in relation to screening on Slido, and what we asked was what our current challenges and support needs. So the question that comes through is, how do we get people to work together?
Fiona?
Yeah, I think that's it is a little bit of a challenge, isn't it? I think the setting out your stall and having that initial conversation in your first community of practice meeting is the most valuable starting point. I think about being honest in terms of what's being asked and the advantages of gaining in the PCN specification. So I suppose it's about being able to articulate what the advantages are for everybody against some of the core elements of the specification. It's about maybe looking for commonalities, and I often find sometimes a leveler to get people engaged is maybe identifying a similar challenge that everybody has, or interestingly encouraging them to share their practice. So that probably the best way that I've seen that happen is in PCNs where they've had the time and space dedicated just a little bit to cover this topic, where they've sent out some pre-asks of practices beforehand. So they've done some preparatory work with some specific kind of tasks that aren't too onerous, just to get the ball rolling in terms of sharing. So for me, it's about having a bit of space, having maybe something to focus on, doing a little bit of pre-prep or preparatory work, and maybe starting with something that's a common challenge or a common success. That makes sense.
No, it does, Fiona. And I think in our own PCN, we sat down and the practices where had the higher cervical smearing rates were asked to why do you have it higher? And they actually shared their invite letters. The other thing that happens is that with Fiona and her team, they also work with the screening team. And certainly in Newcastle, for the No Fear, it wasn't just the CR UK team. We had some people from the screening team who came out to practices as well. And that was quite helpful. So that's working together. And I think the other thing that in Newcastle we're looking at doing is that there is some transformation money for backlog. And one of the things we put a bid in for is to have PCNs having funding to employ nurses for additional hours to do some smear catch up. So there are opportunities if you sit down together and discuss, and usually practices are similar and have a similar kind of issues. And it's just sharing what your situation is, what works well for you, and then agreeing a way forward. And people like the CR UK facilitators can help you contact even the screening team. Is that fair, Fiona?
Yeah, that's right. So yeah, around this one we would support, and definitely it's not just about working with those. We would also, you know, we have a list of people that you could also engage and work with as well. And I mean, sometimes as well, when you're talking about that whole conundrum of working together, some of the case studies, etc., are quite a good place to start, yeah, because it's not related, it's kind of subjective, do you know what I mean? So to having a look at some of those case studies, nobody has to inwardly share straight away, but you're just looking objectively for inspiration elsewhere. So that might be another tactic as well, if people are reluctant to share straight away themselves, but maybe having a look at those case studies might be another starting point.
And the other thing people have is community workers, and the community workers would love a GP to give up half an hour of their time to go and speak to a difficult group to reach. And I've been asked to myself about prostate in the past and things. So that's another thing that you can do, is go out and speak to these difficult groups. It means taking someone's time up, I'm sorry to say, but they would really value that. So Joe, go back to yourself. These slides are all going to go on the website, but it may be a couple of weeks. Is that fair?
Yeah, because we've got obviously the event for the rest of this week, so I would say probably, given where we are in the year, just the other side of Christmas. There will be probably on by then. So just give us a bit of time.
Great. Thank you. Can I have the next slide, please? Thank you.
Can I just add a
More
note,
questions?
Chris,
Yeah.
just in case if somebody was desperate as an individual, they could contact us and we'd send them a copy individually.
Yeah.
Because we have got large numbers. So.
Shortly, we're going to go on to resources, so that'll come up as well. Case studies. Next slide, please. This is from the CIK website, and it's quite small on here, I'm sorry to say, but the top one is restoring cervical screening. Second one is improving screening uptake with low uptake groups. Third one is referral audits. Fourth one's looking at cancer outcomes through referral practices in line with NICE guidelines. These are the examples, and if you press on them, they open up and show the pages that Fiona was showing before. Really good resource. So if you're struggling to know what to do, that's one way of getting some great advice. And again, you don't have to do it, but it's just an example of things you can do. Next slide, please. If you have any further questions, please keep sending them in. Originally, this is going to be towards the end of the talk, but Jonathan Slade's going to be doing his pitch in a couple of slides' time. Next slide, please. Support and resources. Next slide. There's a few things that we'd like to do to help you. One of the things we have is the Northern Cancer Alliance website, and on there we have a primary care, and under primary care is supporting PCNs. So a lot of the stuff we've been talking about is on there, and certainly the one important thing on there is contacts, and that contacts is both for the CRUK facilitator team and myself. And we're very happy to support you, as Joe and Fiona have been saying. Email us, and if you can't find a specific email, send it just to Northern Cancer Alliance, and Sue, who's pressing the buttons for us today, will pass it on to the appropriate person. Also, your CCG cancer lead often will be quite helpful in this, because they'll often know the agendas of your area. They'll know what's going on regarding RDCs and vague symptoms. They can be another valuable resource, and most of those are, I know them very well, and most are very approachable from that point of view. We've also, on the system, we've got the CIK facilitators' contact details as well. We've also tried to do some examples of audits on there. We've also got some paper plans so that you can just populate them yourself with your own PCNs. And if there wasn't one that you needed, I'm sure that Fiona or myself could help support with that. Can I have the next slide, please? PCNs are big things, and everyone wants to help you. Cancer Research UK has a hub, which is on that website there. NHS Confederations has a support. Gateway C is a very important tool. It's a primary care based education service about cancer and all things cancer, including referrals and specific education on specific cancer pathways like the lung or prostate. It's done by a GP from Manchester, who I know very well, and it is very good, and it's very user friendly. It's set at just the right level, I would say. And if you ever need any education, either for yourself or for your PCN, have a look at that. It does some bits on how to do good referrals, and basically have a look at it. It's really, really good. It's also been paid for by NHS Education. I get my brain wrong now. I've got the name, but it's been paid for the whole country for general practice because it's so good. And then there's the Rcgp Toolkit. If you want to do some case analysis, use their website, use their toolkits. And Macmillan have also got some work about PCNs as well. So lots of things out there which are very helpful. As human beings, we're very approachable. Please email us, please send us a message, and we're happy to support you. And I'm speaking on behalf of Fiona and the whole team. I know that they're also very keen to be supportive in this.